Welcome to ASA Central Line, the official podcast series of the American Society of Anesthesiologists, edited by Dr. Adam Stryker.
Hello, everyone, and welcome to the Central Line podcast. I'm your host, Dr. Zach Deutch, and for this edition, we have two experts on the topic of transfusion medicine and blood management. Dr. Nicole Guinn, who is a guest editor of June's ASA Monitor, and Dr. Stephen Frank, who is a contributor to that issue. We'll learn about this important topic, which is highly relevant to all aspects of medical care, and of course, certainly relevant to perioperative medicine. Let's start off by getting some introductions and background information from our two guests today. We'll begin with Dr. Frank. Tell us a little bit about yourself, your professional journey, and your interest in this specific topic.
Sure thing, Zach. I'm privileged to be here, and I'm on the faculty at Johns Hopkins in the Department of Anesthesiology. I'm a professor, and I've been running the patient blood management program here at Johns Hopkins for over a decade, which aims to improve blood utilization. And I also run the bloodless medicine program that aims to avoid transfusions for patients who don't accept them, primarily Jehovah's Witnesses. And my interest in blood really started back when I was a resident, when I personally had a life-saving transfusion. It was a bicycle versus car accident, and I needed a splenectomy, so I was bleeding internally. And if it weren't for blood, I wouldn't be here today. So my favorite cases are traumas and transplants that often end up with massive transfusions, but I also specialize in Jehovah's Witness patients who wish to avoid transfusions altogether.
Thank you, Dr. Frank, and welcome. Dr. Guinn, can you please give a little introduction to our listeners and also talk about your interest in the topic?
Yes, happy to be here as well. My name is Nicole Guinn. I am a professor of anesthesiology at Duke University, where I've been on faculty for about 13 years. Like Steve, I ran our blood conservation program, which was really designed to serve patients for whom blood is not an option. So many of the Jehovah's Witness faith or patients who would decline blood for other reasons. While running that program, we also realized that there was an opportunity to help other patients to avoid transfusion. And so I founded our preoperative anemia clinic and have focused a lot of my research efforts in managing perioperative anemia. I'm the immediate past chair of the ASA Patient Blood Management Committee, and I'm currently the chief of neuroanesthesia at Duke.
Thank you and welcome, Dr. Guinn. We will stick with you for an important clarification and just getting our language and our understanding correct for our listeners and for myself as well. Please define for us blood management and transfusion medicine and talk about the difference between the two.
Thank you for asking about that, Zach. Our special issue really covers both, but they are different. I think of patient blood management and transfusion medicine as two ends of the spectrum that really go all the way from bloodless care to massive transfusion. Patient blood management is defined as an evidence-based, patient-centered approach to a patient's blood health, really supporting their own hematopoietic system, whereas transfusion medicine encompasses more of the appropriate use of blood products and pharmacologic adjuvants. It includes optimal blood use and treatment of coagulopathy. So they really cover everything from not giving any blood products, avoiding them at all costs, to the massive transfusion and everything in the middle. And just about all of our patients can benefit from some of these techniques.
Okay, that's helpful. So we know what we're dealing with. Dr. Frank, let's take a step back. Let's talk about our historical perspective in this clinical area. Where have we come from? Where have we progressed to? And what events in society, culture, whether it be specifically medical culture or generally American culture, have driven us to where we are?
Sure. Yeah. When we talk about history, we have to go back about 40 years because in the early 1980s, specifically 1984, That was the worst year ever to have a blood transfusion because there were people dying from HIV contracted from blood transfusions, because it wasn't until 1985 when they discovered the virus and could actually test the blood for HIV. And by the way, it wasn't until 1990 when the hepatitis C test was developed. So the blood was very unsafe in the 1980s, and people were really afraid of transfusions. So that's part of the story where patient blood management really started. And then along came the Jehovah's Witness patients who suddenly looked pretty darn smart for trying to avoid transfusions while the risk of viral infection was so high. And then historically, we have to go to 1999 when the TRIC trial came out. That was a Canadian study with ICU patients showing that they did just as well when you give them less blood. They looked at hemoglobin triggers and found that even in critically ill ICU patients, a hemoglobin trigger of 7 was just as good as a hemoglobin trigger of 10. So now we have 14 randomized trials since the TRIC trial that have come out that all basically show that less is more for transfusion. And that's why blood use is down over the last decade in the United States by about 30%. So that's the history behind patient blood management.
Okay, well, you've raised a number of questions, but I'm going to try to stay on track and not get us all over the place. I'm going to go to Dr. Guinn for this to kind of focus in on one thing you talked about, which is risks. And you obviously covered the early days and the high level of infectious risks. So today, let's talk about our situation that we have in what we call for ourselves modern medicine. What are the risks of blood transfusions right now, and what options are available for people who can't be transfused for whatever reason? It would be nice to kind of explain to listeners what bloodless care actually looks like in the perioperative setting for those groups of patients that were not able to transfuse.
Sure. So, like Steve said earlier, blood transfusion can really be life-saving in the setting of acute hemorrhage. But it does have significant risks, and not just that risk of viral infection, but also infection from immune suppression. Taco and trolley are some of the more common risks. And we have many, many studies showing that transfusion, whether it's causing it or just correlating it, is associated with higher morbidity and mortality, everything from stroke and kidney injury to MI. So a lot of risks, including death, have been associated with transfusion. And the more you transfuse, the more you increase those risks. So they used to say, if you're going to give 1 unit of blood, you might as well give 2, bring the patient up, kind of the 2 scoops theory. And now instead we say, why give 2 when 1 will do? We should really give the minimum amount of blood necessary to minimize these risks. Now, for the patients for whom transfusion is not an option, we really have a variety of strategies for bloodless care throughout the entire perioperative period that have developed. And it starts early. So it starts before the patient even gets to the OR. You need to identify these patients, check their laboratory studies, make sure if they have anemia, you determine the etiology and you treat it, really optimize their hemoglobin. And Steve and I actually worked together on a paper and a project where you could figure out how much you needed to do that. We used the allowable blood loss formula and rearranged it to figure out, okay, if a patient's starting at this hemoglobin and you expect this much blood loss, what do you really need them to be at preoperatively to minimize transfusion or to avoid it entirely in these cases? So it starts early with identifying the patients, treating their anemia, and also for the patients who decline transfusion, really having the conversation of what is and is not acceptable to them. Because in the Jehovah's Witness faith, what they consider to be minor fractions or things that come from blood like albumin, cryoprecipitate may or may not be acceptable. Once we get into the intra-op period, then there are a whole bunch of other techniques that are available, including use of cell salvage, acute normal volemic hemodilution. Certainly antifibrinolytics like TXA have been really effective at reducing blood loss and transfusion. And then as we move into the post-op period, still thinking about treating anemia, tolerating anemia when appropriate, and minimizing all those blood draws so that we really try to keep the patient's blood in their body. So it really goes across the entire perioperative spectrum.
Okay, understood. I think most listeners understand these terms, but just in case there's some out there that aren't as clear, could you define TACO and trolley as it's currently understood?
So TACO is transfusion-associated circulatory overload, and trolley is transfusion-related acute lung injury.
Okay, very good. Dr. Frank, we talked about some patients that are critical here in the sense that they cannot be transfused. Can you explain to our listeners, who are these patients, what are these populations, and how are we dealing with this?
Sure thing, Zach. Really, all our patients are candidates for patient blood management, and that includes both medical and surgical patients. We always talk about surgery patients, especially the ones having bigger surgeries that have substantial bleeding risk. And for those, like Nicole said, we pull out all the stops, anemia, cell savers, tranexamic acid. Simply keeping patients warm during surgery is helpful so they bleed less. Controlled hypotension, minimizing phlebotomy, blood loss, and even tolerating lower hemoglobins than we used to tolerate. All those are helpful. But we also manage medical patients, such as GI bleeding patients. There's so many people now on blood thinners that a simple GI bleed can be life-threatening, especially in patients who don't accept transfusions. And a few other patient candidates, pediatric patients. Since they're smaller, they have lower allowable blood loss. And we have now several randomized trials showing that even children tolerate lower hemoglobins than we used to target. And then in countries where malaria is a problem, or HIV is still a problem, or there's simply no blood available in some rural areas, all those locations are appropriate for patient blood management. So I'd say a broad spectrum of patients are all candidates.
And it sounds like we should bring a degree of sophistication and conscious stewardship to all of the care that we give in medicine regarding this. And your answer really speaks well to that. I would like to ask a question that came up when both of you were answering these past two questions. We talked about what was acceptable for patients based on their beliefs. And I've also seen in medicine some ethical and philosophical concerns raised by practitioners who felt that doing a certain procedure on a patient who refused to accept blood and in these type of circumstances was not acceptable to them. And they felt it was a violation of their ethics. I would like both of you to comment on that. Dr. Guinn, we'll start with you, please.
I've heard of this, and I've run into people who would not agree to care for patients who would decline blood for this reason. And I've often kind of thought of it similar to a patient who chooses to be a do not resuscitate. And they may choose that for a variety of reasons. I think if we think that we can't care for the patient, if it's not feasible, it's not possible, that's one thing. If a patient needs a surgery that cannot be done without transfusion, then I think you have that conversation with the patient and say, if you do not accept transfusion, which is their right to decide what medical treatments they do and do not want, then we can't offer you this surgery. But if it's something that can be done, and we have a lot of tools that have helped us to be able to do more and more, then I do think it's patients' right to decide what happens to their body and what they accept and what they do not accept.
Have you ever been faced with a situation you thought was absurd in this regard in terms of the risk benefit or the demands of the surgery or whatever the clinical circumstances were, and it was a patient that couldn't be transfused and it looked like there was going to be significant risk to the patient? I'm curious what your thoughts have been when personally faced with that or any scenario that you faced.
I can take that first. Zach. We've been running a program for patients who don't accept blood for 12 years now. And there's only really two types of cases that we thought might be too high risk to attempt without transfusion. One is a liver transplant, which some places do and some places don't, but it's still very high risk. And the other is a thoracoabdominal aortic aneurysm. And we all know those are like a scheduled exsanguination event. So there are some cases that we think are too big, but those are few and far between.
I would agree with Steve. I mean, we've done heart transplants, numerous heart transplants without blood. Liver transplants, I think, are more challenging cases. And another case that I recall that we agreed as a team after a lot of discussion that we didn't think we could perform without transfusion safely was a patient with an acute aortic dissection that would need a massive aortic surgery. And we had really no time to optimize them.
From the ethical standpoint, the patients that we're most concerned about are pediatric patients with Jehovah's Witness parents. They fall in a special category because, at least in the United States, parents are not legally allowed to refuse life-saving therapy for their children. So we have to handle pediatric patients with Jehovah's Witness parents with special care. And what we do is we tell the parents all the things we're going to do to try to reduce or avoid the need for transfusion. And we tell them about cell savers and tranexamic acid and keeping your child warm and minimizing phlebotomy blood loss. So they like to hear all these things we're going to do to try to avoid transfusion. But we also tell them if their child's life is threatened, that we're legally obligated to give them blood. And I think the parents like to hear that sometimes as well, because it takes the weight off of their shoulders. And we tell them that, hey, we're going to save your kid's life. And we've shown that only 6% of pediatric patients actually get transfused under those circumstances.
Dr. Guinn, do you have anything to add?
We've had similar experience at Duke. We have parents who would not want their children to be transfused to sign a form, their acknowledgement form, where we acknowledge that we will do everything we can to avoid transfusion, and they acknowledge that both hospital policy and law requires us to transfuse should it be a life-threatening emergency. And I think it does take some weight off. They're not consenting to transfusion, but they are acknowledging that this is the law, this is the policy, and we're acknowledging that we're going to do everything we can to avoid it.
Okay, and I think that based on what you all have said already in this podcast, the sophistication with which we approach this clinical issue has allowed us to obviate a lot of these problems because we just are not transfusing as much, and we're able to manage patients with low levels of hemoglobin we wouldn't have even dreamed of in the past. So that's kind of a big help in this regard, which brings me to my next question for you, Dr. Guinn. Talk to us about advances in transfusion medicine that we've seen recently, and which of those you think are the most important and noteworthy.
Well, I really think the biggest game changer that we've seen in the last decade or so has been with antifibrinolytics, especially TXA. There are just numerous studies showing in all kinds of different patient populations that it's effective at decreasing blood loss and transfusion. And it is inexpensive, easy to give, readily available. So I think that's something that globally has made the biggest difference in managing patients without transfusion and decreasing transfusion needs.
Okay, so let's talk about the future, the path forward, what advancements are coming. And I'm going to address to both of you this question. Talk to our listeners about what you see coming down for the future of transfusion medicine, and also talk to them about what you see are problems that could arise to delay or hinder advancements. Dr. Frank, I'll start with you, please.
Yeah, sure. Trying to predict the future is never easy, but I know that we're all hoping and wishing for a viable blood substitute. For literally 100 years, we've been looking for a safe and effective blood substitute, and a few have tried to come to market, primarily what we call hemoglobin-based oxygen carriers. And it was about 25 years ago when these were all the rage, and most of them are bovine hemoglobin-derived large molecules that are polymerized, and they carry oxygen, but they also have side effects like nitric oxide scavenging and some renal toxicity. There's even a meta-analysis showing increased ischemic cardiac events that put the brakes on artificial blood or blood substitutes back in 2008. But there's a resurgence of interest and funding right here in Baltimore at University of Maryland, and there is some hope that we might see a blood substitute in the near future.
Okay, Dr. Guinn, it's your turn. Look in the crystal ball. Tell us what's good that's coming, and tell us what bumps in the road we might see as well.
So I think we can't look at the future and not think about large data and AI and predictive modeling and what that's going to do in all different fields. And I think there's really opportunity in gene medicine and patient blood management for this to happen. As Steve mentioned way at the beginning of the podcast, ever since the trick trial, we've been going off transfusion triggers, which are the opposite of individualized patient care. They're just a random number when so many other things play into whether a patient has adequate oxygen carrying capacity. So I hope that AI, predictive modeling, large data sets will help us to really individualize transfusion medicine and patient blood management and think about really which patient needs which products and how much. And I'm hoping that data will come and help us to have more targeted therapies so that we have the benefit without the risk.
Okay. We're coming to the end here. So I'm going to have a question for both of you. After having participated in this podcast and having been contributors to the issue of the ASA Monitor, talk to us about what you really want as a take-home message for our ASA members regarding transfusion medicine and blood management. And Dr. Frank, I'll start with you.
Sure thing. Take-home message is now we have 14 huge randomized trials, all showing what I call less is more for transfusion, most of which have come out in the last 10 years. So people are still trying to adjust their transfusion practice to this less is more approach. But the other take home is there's many ways to benefit our patients without giving blood. For example, Nicole mentioned pre-op anemia treatment, but there's other methods of what I call keeping the blood in the patient, that it's much better to prevent severe anemia than it is to treat it with either transfusions or either iron or erythropoietin. So keeping the blood in the patient is very important. And like Nicole said before, blood saves lives when you need it, but only increases risk and cost when you don't.
And also a cautionary tale for our listeners, be careful when you're on your bike, correct?
Unless you want to donate your spleen to a trauma center, that's good advice.
And I suppose it depends on where you live, because here where I live in Florida, people love to bike because the weather's nice, but there are no good bike trails. And we unfortunately see a fair amount of bike accidents. So we'll try to think happier thoughts about that. And if you do get into an accident with experts like you at the helm, maybe you won't even need blood anyways. Dr. Guinn, share with us your take-home messages and final thoughts for listeners, please.
So Steve said two of my favorite things: keep blood in the patient, and blood saves lives when you need it, but increases costs and risks when you don't. I'll add one more, which is try to get to the patients early to make the biggest impact, to really optimize hemoglobin and treat anemia. We really ideally want to see them 4 weeks ahead of time. But that being said, it's never too late to make a difference. We can even treat anemia post-operatively and decrease transfusion and help the patient feel better when they go home. So really don't forget to think of anemia as a modifiable risk factor and not just default to transfusion.
Thank you both for joining us. I've learned a lot. It's been an interesting topic to reflect on, given that if you've been in this field of anesthesia or perioperative medicine for a while, many of the things, as you all pointed out earlier, that we've been taught about physiology, blood management, oxygen delivery are really outdated. And we've seen just how far we can take our frontiers in terms of protecting patients from other risks while still maintaining their health. And that's excellent. So for listeners, I hope you enjoyed this edition. I want to thank both of our experts for being here. And you can always go to asamonitor.org for more information about this topic or any others. And we look forward to seeing you on the next Central Line podcast. Take care.
Hi, this is Dr. Deborah Schwengel with the ASA Patient Safety Editorial Board. Cognitive biases are a significant problem in medical decision-making. Flaws in judgment, rather than lack of knowledge, are central to diagnostic error. The most common types of bias are overconfidence, anchoring, and confirmation bias. Steps to mitigate errors due to cognitive bias could include raising awareness by defining and discussing the terms heuristics and bias, reflective practice and cognitive bias awareness, challenging your own biases, becoming a more critical thinker, and acknowledging that some unknowns are unknown. We must acknowledge the contributions of bias to our medical decision-making, embrace the opportunity to use metacognition techniques to think critically, be open to alternate analyses, and be reflective in your practice of medical decision-making.
For more patient safety content, visit asahq.org/patient safety. Do your part to advance the specialty by participating in a quality registry through Anesthesia Quality Institute. Support patient safety, compliance, and business objectives at aqihq.org/registries. Subscribe to Central Line today, wherever you get your podcasts, or visit asahq.org/podcasts for more.